Yeah, so really we've seen the whole gambit. We've on the training side, whether we've been delivering training courses for clients or whether we've been attending additional training, given the rapidly evolving landscape. There are huge considerations around that. And I think for the most part, actually, people have been very amenable, they've adapted very well. And it is a case of, I'm almost sick of the phrase, the new normal, but actually, if you're training in an environment where you're having to consider COVID, by its very nature, you are therefore preparing yourself for what you should be doing day in, day out, because it's not a course-specific consideration. It is now a life consideration and what we're doing. On the flip side, operationally, we've been supporting clients with medical care, whether that's up to and including providing kind of almost intensive care level equipment on standby should the need arise, with kind of your doomsday scenario, which fortunately wasn't the case. Up to kind of just the basic advice. What can people do? How can people avoid the need for that trip to hospital? What do people do when their normal route into private healthcare, for example, no longer exists because that capacity has been taken back by the NHS in preparation, or presents the risk itself by going to a healthcare facility? Are we exposing our client to greater risk than needs be if we could bring that healthcare solution to them in their own home or in their own environment? So yeah, it's been fascinating.
Yes, it's a big learning curve, big journey. The floor is yours. Very happy to hear your thoughts on training requirements in this area. You can share your screen, I think, if I allow.
I was just about to say it's currently saying that I'm
yes,
disabled from showing my screen.
I've now enabled it. It's that wonderful security thing.
Fantastic. Okay, so hopefully, all being well, this will now pop up. And are you happy? Are you able just to see the full screen of the first presentation?
Yes, it's all good.
Fantastic. Okay, so I thought I'd break this into the two main areas, which were initially the healthcare planning itself, but also then consideration around training, whether that's delivering training, undertaking training to try and move through. So as an overview, just bear with me, looking at healthcare planning itself, both for the individuals on a team or a whole team approach, depending on the resources you've got, the size of your team. Also looking at healthcare planning for your client and the considerations around that, particularly as we now open up, the lockdowns are easing, considerations to family, to friends, to other acquaintances that they may be coming across day to day, and considerations towards that. From a training point of view, there's the statutory and mandatory training, so things that people will have to do. There will come a point where people are due refreshers, whether that's for their first aid or whatever courses they've done, and looking at those must-dos, but also some consideration around elective training or bespoke training. As you've alluded to there, people are interested in how they can progress their medical training. It was interesting, just listening back to the last panel, the idea that there's entry-level training in a lot of areas, but actually that progression training. How do we go from the kind of awareness of or the base standard of a knowledge base and move that up to become perhaps the team medical, or expand our own experience within that. So if we start just looking within the individuals and teams themselves. So the first and hopefully obvious thing is to consider the prevention options. What can we do to try and not get this in the first place? Hygiene is a big key, and the simple stuff, washing hands, soap and water, is still one of the most effective ways of preventing this. The hand gels and sanitizer gels certainly have their place. They are very effective, and particularly in the absence of other options. But one thing that we found hasn't necessarily been highlighted as much is that those gels are only really effective up to about 5 applications. Beyond that, they cease to do the job they're supposed to, and actually you just end up with kind of claggy hands. You then need to wash your hands, clear it off, to then be able to make use of the gels again. They're really a stopgap until or unless you can wash your hands as a preference. PPE, everyone is used to the face mask concept, so I think that's probably the most obvious one to consider. the fashion masks, if you like, or the foam masks really are almost useless. You may as well not be wearing anything. You need to be looking at least triple ply material masks to try and prevent this, or the surgical grade masks. Realistically, people are not going to want to be walking around in medical looking masks. So make sure if you are sourcing these yourselves, that they are definitely triple materials. If you can have a filter layer in between, fantastic, but that's probably going to fit better with the corporate environment than walking around in medical masks. Isolation and bubbles are very very useful, certainly if you have the numbers to do that. We've had instances where we're isolating a team in advance of being deployed, so that we are confident that they haven't got any symptoms, they've managed to isolate as the group that's going to be going out and working. And I know, speaking to some of the teams out there, that's being put in place, even small numbers, if it's pairs back and forth. But that really does make a big difference. And if you can operate in those bubbles as best as possible, you're going to limit the opportunities of infection while still being operationally effective. The detection is an interesting one at the moment. Really, symptoms are the first thing we want to look at, and we'll have a slide for that later on in the presentation. The symptoms, or the key symptoms that are being looked at, are different in different countries. So try and find out what your local advice is. But also, you are more likely to recognise the symptoms sooner. That may then prompt a test, but you need to act on the presence of those symptoms. If you are in the fortunate position where you are able to do frequent testing, and we're seeing that in the film and TV industry particularly, as well as within obviously CP environments, you can keep on top of things, and the second something presents, particularly with these silent spreaders, your asymptomatic sufferers, where they may not have those symptoms, and you're able to pick it up with either swab testing or blood testing. There are still, unfortunately, organisations out there trying to sell tests that are not effective. So I'm not going to promote any specifically, but do your research or speak to an organisation who is going to have that knowledge to get you the right test kits. We've put a lot of time into that ourselves, making sure what we're recommending is the right thing to recommend. Don't be swayed by the later Instagram or LinkedIn post. It may not be as reliable as you would hope it to be. Track and trace has had variable success within the UK. Whilst it's received fairly poor press, as we'll all know, there is a place for it. And actually, you can implement track and trace locally and within your teams. As long as you've got good contacts of who's working with whom, where you've been, that really is about finding out how you can really put in place damage limitation. If someone does start to develop symptoms or is testing positive, be able to try and isolate the people you need to maximise the operational effectiveness of everyone else you have, so that you can not just isolate everyone who might be at risk, but really dial down to those who are genuinely at risk, having been exposed, and maintain the freedom of the rest of the team, so that they can still do the job. Plan cover, that's part of the bubble initiative anyway, but also know your timelines at the end of the presentation, but know how long people are going to have to isolate, both if they are symptomatic, but also if they have been around someone who's symptomatic and also need to isolate. And then cleaning. There are now products out there which we've managed to find that are actually able to not only clean there and then, but provide a protective element that will kill up to 99% or more of COVID up to a year even. So that's something well worth investing in and looking towards, so that you've got that ongoing safety net. And then the recovery phase itself, so monitoring. Look at other people, make sure you're picking up on those symptoms, make sure you've reassured people, have the confidence that once they are passed, once they have tested negative, they are okay to reintegrate. Truly, nobody knows where we are in terms of long-term resistance to this. People who have had COVID-19, there are certain instances where they have re-caught it. But what's important to note is sometimes that's not the same strain. So people have perhaps caught it in one country, travelled to another part of the world, and they've caught a different strain because this is an evolving disease. They've caught a different strain. They may still have the immunity to the initial one, but it's just not clear enough yet. And we haven't had long enough to know where we're sitting with that. And vigilance, make sure that just because someone's had it once, you don't assume that they are therefore immune for forevermore, and that you can pick up on those signs if anything does develop. So when we look at the client side of things, the initial considerations are exactly the same, but we also need to consider that it's not necessarily as easy to control or encourage or insist upon things with the client as it might be for a member of the team or someone in our direct control. So looking through here, some of the things we've certainly come across are reluctance to comply. Often we're working with people who are not used to boundaries. They're not used to limitations in anything they do in any walk of life. So whilst lockdown has inevitably been difficult for all of us, actually this is something of a complete change in mindset and lifestyle, and they simply don't want to do it. Consideration either the rules don't or shouldn't apply to them, or that they can work within those rules because they have such estates or plural perhaps, they can move around within their own environments really without impacting or affecting other people. So it's a different set of considerations. Denial, there are still people out there who are convinced that this is either entirely made up or exaggerated. I'm not going to get into the politics of it, but that is something that potentially you're going to have to come across in your planning phases. A lot of this can be background work, stuff that you're doing as a team or trying to make happen, not necessarily without the involvement of the client, but without them having to consider it, doing everything you can in the background as you would with any other element of CP, with minimal impact on them, but still getting the benefits from that. In terms of paranoia, that can have the reverse effect. We've worked with people where almost they've completely shut down and locked down. Arguably, actually, that's one of the best things you can do. That pure isolation, absolute hard line between inside and outside, which is good. But there are instances where, certainly from a healthcare point of view, we need to get to the client. We need to be able to see them. But their degree of paranoia is such that they don't want to bring someone in. This is where resources can be beneficial because they rightly may be concerned about the 999 response, or depending which country you're in, the local ambulance service, for example. There's a very good chance they've been exposed. So actually bringing that person in is a risk. Whereas if you can have a dedicated resource that can come in for you, to you, has perhaps been isolating up until the point of need, that can assist certainly with that, to try and encourage them to do the right thing. Business necessity and image is unavoidable. There are going to be times where people have to move, they have to do things, they have to be potentially exposing themselves to risk. The image side of things is almost two-sided. On the one hand, you've got their image, and we've seen this with everyone up to world leaders and business leaders, not wanting to be seen with a face mask, projecting that image. Their argument, they're being tested regularly, therefore they're safe, they don't need to wear a mask. And there is, to a degree, some truth in that. However, the flip side is with image comes responsibility, being that role model, making sure that they are seen to be doing the right things, to make sure that anyone that they are having as followers, people who are influenced by them, people who look up to them as a role model or a responsible person, is seeing the right thing. And actually in that case, you may have a situation where you can assist with that by ensuring they are complying, they are doing what they need to be doing in order to promote that positive image. Some of the benefits, again, actually this paranoia can reap rewards. They are more willing to comply with what you're asking them to do, particularly because they are concerned. And we've, to a degree, had an experience with that where people are so concerned about their health and well-being that they are now putting in place what was initially a COVID response or healthcare response, but actually see the longer-term benefits of that now. If you have got a direct line into all medical response and facility, whether that's routine, your blood tests, routine medicals, up to emergency response, and even some hospital considerations, that can be brought to the home. And I think we'll probably see an increase in that, people investing in medical suites within their own residence, or a response element that can come to them and is clean, is dedicated for them, and not being shared with others. So that will be an interesting thing to see. Acreage and resources. Obviously, if they have a huge building, huge facilities, huge space, that improves the well-being in terms of isolation and lockdown. They're not in their 17th floor flat, so you have a bit more space both to separate teams, to isolate people, but also to minimise the impact of what is a very challenging lockdown, and has been for many people. Independence of travel. This is both internally and domestically, but also internationally. If you've got your own aircraft, then you're not having to face some of the same challenges with airports, air travel, and therefore there is a bit more freedom. The friction there is with lockdowns coming into a country, a lot of that being based around the idea that you have been mixing with people. Well, potentially you can mitigate against that, but depending which country you're in and out of, will depend how that is viewed. But also consider that if you are responsible for planning for healthcare response, you don't necessarily have to limit yourself to the local resources. So if you've got input or access to healthcare facilities around the world, have those conversations now. Build those liaisons so that if the need arises, you can move people potentially internationally to facilities as countries ebb and flow with their risk and with their levels of coronavirus. It's worth considering now rather than when you're actually faced with having to do it. This next slide I thought might be an interesting one just to throw in. Those of you who are already medics or are part of the medical response, it's a difficult one to try and get a mindset change because this is an invisible threat. The way we've looked at it, certain terms of frontline responses, is you almost have to look at this. If you're responding into a patient that you're not routinely interacting with, therefore not part of their bubble, you look at it as a house fire almost. You wouldn't walk into a smoke-filled room without the appropriate personal protective equipment, without breathing apparatus, without respiratory protection. You have to have the same approach to coronavirus, to COVID-19. So this is just a slide. It's actually taken from some of the London Ambulance Service publications. And even in a cardiac arrest, frontline response is stopping you. We're putting on the PPE before going to the patient, which is incredibly difficult, and certainly in the first instances is a difficult mindset to get in. The instinct is to go in, to get involved and to look after the casualty, but you've got to be ensuring that your PPE is available, that you know how to use it, and that you're confident in its use should you need to respond to your client or to someone who's within your responsibility. If anything, in terms of additional training, that is one thing that is very useful, is actually looking into PPE. How is it supposed to be used? What levels are you supposed to use? And often overlooked is how do you take it off again, which sometimes isn't a consideration that people have. Moving on slightly is onto the training side. Excuse me while I move my chat window. So the statutory and mandatory training, things that we are having to do. Consider, know what you have to do, but also when do you have to have it done by. Look ahead, get your training matrices in place so that you know who is going to need this. But one of the things that may be of benefit is a lot of organisations have actually extended expiries. So if you were coming to the end of your ticket and needed a refresh, that may have been pushed on. Keep an eye on that though, because there are cut-offs and people are already starting to trip up in terms of when their qualifications are needing to be refreshed. And also when you do need to refresh, the availability of courses, because you've got this perfect storm where there's a larger proportion of people needing the training because they've been holding back, the timelines have been extended, so there's now a greater pool of people needing the training. But we may have fewer places on courses if space is at a premium, in order to allow for your social distancing, for the number of bits of kit you now need to deliver training so everyone has their own equipment. These are things that we definitely need to consider moving forward. Plan in advance, and the idea of COVID safe businesses applies to your training provider as much as it does to anybody else. Have the discussions and considerations in advance, and actually think about whether from a risk reward point of view, it is better to bring the training provider to you, even if that means arranging for a cohort of people, or perhaps putting people to recertify a few months earlier than they would need to, so that you bring one trainer or one set of kit to you to provide the training, rather than load onto an open course perhaps, where you're exposing the individual both to the other people on the course, but also equipment that may or may not have been kind of cleaned as much as it needs to, will be used by all those other people. It just adds a layer of risk, and if you are able to mitigate against that, then I would highly recommend doing so. Bespoke and elective training, and this kind of leads back to what Thurman has been saying in terms of people looking for more. Don't necessarily just think about, right, what kind of medical topics can I do? Think about the COVID specific training, whether that is around personal protective equipment, whether it's around pandemic planning, about a more healthcare or prevention side of things, because this is not something that as a medic you are going to be able to necessarily treat yourself. If someone does get ill enough with coronavirus that they need intervention, it is going to be professional intervention that does that. This is not your cat bleed where you can stick a tourniquet on. This is not your cardiac arrest where you can do your CPR. There is not a lot you can do other than identify and seek that professional support. You are better placed putting your focus onto prevention, focusing on how you can avoid getting it around isolation, monitoring, track and trace options. So whilst it's not kind of sexy, glamorous medicine, that is absolutely where the key will lie. Equipment selection, so contactless thermometers, gloves, sanitizers, all those kinds of things which are mundane, yes, but really will make the difference. And the households we've been in where we've been most impressed, if we've been asked to risk assess their processes, are where they've done exactly that. There's someone dedicated on the door to signing in and signing out, to taking temperatures, to recording those, and actually acting on those temperatures. If they are outside of range, denying entry, as unpopular as that may be. These really are the most important steps that you can take in terms of prevention and ultimately protecting your client, which is what it's all about. And this is an evolving pandemic, so there is no such thing, or should be no such thing, as a coronavirus course or a COVID-19 course. Even now, if we compare this to 6 months ago, and as Phelim said, we had this chat at the beginning, what were we expecting? What did we think was going to come? If I'd written a course then to deliver about what COVID-19 was, how you recognised it, and what the isolation processes were, it would be different by now. So you're essentially trying to write a course that is out of date within a matter of months. You're better placed trying to look at where can you get reliable information. What are your best sources locally? And there's a very good reason I'm not giving you lots of facts and figures at the moment, is because it changes almost daily. It also changes depending which country you're in, which region you're in. Those of you in the UK at the moment, you'll know each part of the UK at the moment has a different approach to this. Over in America, there'll be different approaches again, and all around the world, there'll be different approaches. So know where to find your reliable information, more so than try and get sold on a course that this is going to provide you your COVID-19 response training, because it's principles around prevention and control that will be more beneficial and more applicable generally than specifically learning about what coronavirus is or what COVID-19 looks like today, which may be different 6 months down the line. And on that basis, in terms of training, it needs to be about how this applies to your role. How can you apply this to what you're doing day to day? So we've looked at this in terms of the silo mentality, and you almost have to accept that that's an inevitability. So what you need to do is, if you're responsible for your COVID planning or your healthcare planning, know what you need to be doing and then make sure that that's being done across the board. Accept that there will be differences in what different groups or different parts of the puzzle are doing, but have consistency in approach to this. That would be the best way forward. And it's difficult sometimes with the accreditation. Accreditation absolutely has a place, but as much as there are debates around the SIA and accreditation and what's right or wrong, as soon as you have a standard or a base standard, the risk is that becomes the standard. It's no longer a base standard. It's all you need to get in, and therefore no one will do anymore. With a rapidly evolving scenario such as the coronavirus pandemic, you almost need to be able to tap into a trusted provider who has got the up-to-date information, but it hasn't necessarily gone through an accreditation process, because that takes time. And also, as we said, an accredited course 6 months ago would no longer be as valid because things have changed. So know when an accredited course is valuable. So your FREC courses, your first person on scene courses, your first aid at work courses can be accredited, and for good reason. But there is also a time not to get hung up on that, not to think, well, that's not accredited, therefore it doesn't count. It absolutely does and can. And if you've got trust in your provider, they are going to be your best resource in doing that. So as I'm saying here, the silo working is inevitable. Have the overview, make sure that the principles are being delivered to each of those silos, rather than expecting that they're all going to change and drop into the same thing. So almost as a recap, just to finish off, this is UK based. This is as of today, and just looking at some of those main symptoms. So the high temperature, the cough, and loss or change of smell are the three key things that we're looking for. If anybody develops those symptoms, you need to react as though that is coronavirus until proven otherwise. Yes, get the tests arranged, but treat it as though it is until you've proved otherwise. If someone has got those symptoms or does test positive, at the moment, and there's been a fairly recent change in isolation periods, it's now 10 days isolation, either from the point of the symptoms, or if you get a positive test, it's from the date of that positive test moving forward. And then if you live with someone who's got symptoms or has tested positive, you need to be looking at 14 days isolation, because there is the incubation period where it may not be apparent someone has it. There's also the consideration about the asymptomatic or non-symptomatic sufferers who may still be passing this on, so need to self-isolate until that time has passed, or until such time that they've got a reliable negative test, and that will prevent the spread as best you can. So last thing really is that there is not going to be an end of pandemic. Yes, there may come a time where we decide that COVID-19 has been eradicated, but there will be something else thereafter. There may be COVID-21, it may be a completely different pandemic, but the lessons that are being learned now in terms of PPE and pandemic response and training will be applicable to any pandemic of this nature. So it's not going to be wasted time to learn how to respond to it now.
Great, thanks, Paul. No, that's a fantastic tour de force. And as you say, you know, we could have airborne Ebola next. So we need some sort of planning, even for skeptics out there. At least this is one good exercise if you're a skeptic, and if you're not a skeptic, then of course it's good preparation.
Absolutely.
Of course, you're not advocating everybody goes out and becomes a medic. Is there space for somebody who's an EPO to do some training that's going to be of benefit to them, or should they leave it to the medics?
I think actually at the moment there's probably a middle ground that may not have been considered as frequently previously, and that is you have your medical training anyway, or within the scope of a CPO or EP operatives. Look for top cover more than becoming the expert. So if you have your team and you've got an established medic within the team, you don't necessarily upskill them to become your paramedic or your doctor, because they're not going to maintain the currency. Build a relationship with someone who does have that input, and then you can be the eyes and ears on the ground and have that access to top cover that can either advise without having to go to a facility, can come to you if needed, and again try and maintain the bubble and keep people down to a minimum, or if it is absolutely necessary, oversee the transport to a proper facility. So don't expect to become the expert, because it's not going to be achievable, and certainly without the exposure to patients and years behind you. Know how to get that next level of care, and always become the professional liaison, the professional medical intermediary, because those teams can upskill your knowledge base and still develop you as a medic without you having to be everything in one bag.
All right, Fantastic. Well, we are now out of time, but it's great to see you again, and great to sort of have an update, as it were. 5-6 months has well flown by in some sense, and not in others. So Paul, it's a pleasure to welcome you, and we look forward to seeing you later in the day in the audience.
My pleasure. Take care.
Thanks a lot. Fantastic. Well, thanks a lot, Paul. That's